as usual, we will ask a few summary of this 3 days marathon, and we will go. Is there a specific slide? Maybe next. With 3 rapporteurs. First, Jean-Pierre Routy will try in 10 minutes, 8 minutes, to summarize the HIV prevention data that have been presented during this Congress. Then Sabine Kinloch will present the clinical and therapeutic aspects of HIV, and Philippe Alphon will do the whole HCV summary. So thank you for having worked during the meeting despite the lack of time.
Merci Alain. So it's Friday afternoon. We have to go fast and to put the highlight of prevention. So we know biologically that there is factors from the infectiousness. So that's the person having the virus, and susceptibility, that's factor linked to the person who may receive the virus, the HIV acquisition. I think the highlight was put mainly on the acute infection, because during the chronic phase, heart can decrease the community viral load, but not during the early phase, because patients are not treated or not aware, and remain a very important limitation. And then we can see that HIV medication can be used in absence of vaccine with a very unexpected high potency, nearly 100% in the partner study. So it may also display or displace the role of vaccine, and it will be very hard to do a preventive vaccine without 100% efficacy if the control arm will be standard of care, serodiscordant treatment, and then he push the number of, to do a vaccine trial, multiply by 3 or 4 the number of participants, and therefore the cost and the duration. So it's a mixture between also physician, behaviorist, prevention, and that's people work together. And initially, using medication as a bit discouraged psychologists, behaviorists, because everything was given back again to the physician and to drug company, because they have to be monitored as healthy individual. So the big things, and Julio Montaner could not comment much because his father died 4 days ago, and he will not be able to join. But so in his mind, and we discussed that 8 years ago, that he said, well, it's good what you do in primo-infection, but you find 5–10% of the population, so what you do is of no importance. Me, I take the chronic infection, I will treat them all, and then I will block the epidemics. So maybe both were not wrong. So you have to treat the chronic population, but you will not stop the epidemics, because we show with the cluster analysis with Mark Weinberg and Bluma Brenner with the primary HIV infection in Montreal that there is a 10-fold increased transmission by recently infected person when compared to years of follow-up. So there is an absence of blockade antibody, high viral load, unknown status, and that makes the distribution very high on top of the simultaneous number of partners. It's better to have 1 partner every week than 10 in one night. So it's a mechanical, mathematical construction. So it's better to be a serial monogamer. So prevention, you know this slide, and I think we're very pleased to have Maren Cohen, who is the king of prevention from a laboratory perspective. We gave, I think, an outstanding talk from biology, behavior, and transmission and acquisition. So we can put the medication anywhere. So, and then if you put the medication anytime, not anywhere, in your body. It will depend on the type of medication, if you go more in your rectum, in your vagina, in your penis, in your sperm. So the distribution of drugs may matter, and Truvada, tenofovir, has a very good genital distribution, and also the new integrase may have a good tissular distribution, like mucosa tissue. So there is also transmission or factor may depend on the class, the type of medication, and it seems that it may matter, and there is good animal model for that, more difficult to study in humans. So there is a lot of prevention, and the FDA have accepted to use that as a preventive measure with the Truvada. Of course, you can use topical agent, and we had news about the famous ring that can be linked to control birth control and HIV. And there is the injectable medication, and the Maraviroc, with not too much use, may have a second chance by having a prophylactic benefits in non-infected, so in healthy subject. And of course, we have to know if the CD8 increase in the mucosa, the paradox of Maraviroc, we should decrease inflammation, may have a CD8 expansion of the lymphocyte CD8 in the mucosa, so we still don't know this paradoxal, unexpected effect. So there is also the new TAF, the new long-acting Truvada, and they have a good lymphoid distribution, and may have a good also deep tissue distribution, and may also have a good effect on prevention due to the long intracellular life and deep tissue penetration. And of course, there is the advent of the new long-acting dolutegravir prodrug, and you can see on this slide that was not presented, that on a mucosa distribution in rectal and plasma 744, you have a very linear correlation. So more you have in your blood, more you have in your rectum, and it can be a way of HIV acquisition. And in human and in macaques, the drugs may stay a month, and we learned yesterday, or I learned yesterday, that it may stay even years in your rectum. So evaluation and this study are ongoing, so I learned that, and it's very interesting because it can be intramuscular, so compliance can be overcome by gratification of the healthy high-risk individual by paying some food, some cups, some reward to be undetectable, as in certain centers in US, IDU are paid to become undetectable versus non-being paid, and this study is ongoing at Drexel University, Philadelphia. So other study looking at other study, maybe the coming of the true blockade antibody. It's maybe a new era, so we need to see that, because years and years, but it seems that there is a common or persistent structure that can be highly immune eliciting. And also the good news from animal model, B cell may play a role of T cells, so they may be a receptor, and then they may participate to CTL activity or be a kind of B helper for CD8. So there is a new role of the B cell above and beyond the antibody. They're not just a factory of antibodies, they act more like T cell, or what we thought in the past. So then there is the infected. If you treat all, including in primo infection, then epidemics will decrease. So treat them all, so that's a kind of motto. I learned the T3, so it's test and treat them all. So I don't know which is number 3T, but maybe treat and test. So anyway, T3, you treat and test and do everything. And so we have to stop the virus earlier, so the difficulty, drugs, HIV medication works, but you have to find the patient before infection or very early, why not the day before? So we can see once again that there is a persistence meeting in Miami, but you will even learn more during the next Marseille meeting in 2016. Thank you.
ou juste comme ça pour avancer là, c'est ça? Puis après, j'aimerais juste là, ouais. Good afternoon. I'm going to try to go very quickly because the sunshine is out. So I'm Sabine Kenlock. I'm an old HIV-ologist. And I think I met the group ISHEID and Alain probably in 1994. Doesn't make us feel very young, but anyway, that's life. Okay, so conflict of interest, I've got a few, but mostly I've got a conflict of interest to all the speakers who I've pinched their slides from just to make this quick summary. So I'm going to be unable to cover all the presentations, but I just want to talk about mostly antiretroviral therapy, because I think the state of the art is very interesting, and we've got new potency, potentially low resistance, and a very exciting drug development pipeline. And because Alain is here, and because we've been interested in this for a long time, I think a little bit about eradication. Okay, so what we know now, we've got lots of compounds, about 25, and we have long-term toxicity, we have aging people as patients, adherence problems and comorbidities as well as resistance. Thank God we've got newer compound, and we've got a very robust pipeline of new drugs from all classes. The potency and the resistant type of these compounds is being revisited with really the generation of very exciting compounds. We also have gene therapy. I'm not sure I'm educated enough to talk cleverly about it, but I will try because I think it's an important part of this conference. And the eradication. So basically, we would like to have drugs which we can deal with regarding all these comorbidities. And as we know, we've got all sorts of events in patients, cardiovascular diabetes, bone and kidney, which are rising with an aging population. And we have long-term treatment in the absence of eradication, and we would like very low or no development of resistance and a decrease of side effects in the short term and long term. Also, we need to have our patients who've got long-term adherence, and we have new strategies which have been discussed during this meeting. We also should never forget that there are very important issues in resource-limited countries, children and adolescents. And of course, as discussed before by my very eminent predecessor here, we have discovered a few years ago the effect of heart as a public health measure to decrease the epidemic. And unhappily, it has cost. But thank God we are having generics coming up. So money is everything, and I think it's been talked about during this conference. This is the NHS and my colleague Mark Nelson's bottle and money. Well, this happens every day. And although we have all the good things I've been telling you, we still have got problems because we're going to have to pay for it. So if we look at all the antiretroviral therapy compounds, as you can see, we've got many classes, and we've got also the development in all classes of new compounds. And that's very exciting. When I started in 1988 to give antiretroviral therapy, I had one drug, and actually we did a very nice study with it, but anyway, that's it. Now we have a very potent armamentarium, and we can get up to 90% undetectability if we work properly. And that's very important. That's our aim, and we shouldn't sort of fail patients. I think it's been discussed in this meeting. So up to 90% of treatment-naive can achieve undetectable viral load. So if we look, the problem is all these drugs, particularly when we start with them, they look very exciting, they have no toxicity, and then, of course, we discover they have short-term, but mostly we don't discover early enough they've got long-term toxicity. And you know all this because you're all very clever clinicians and experienced, and so unhappily we get a bit disappointed by these drugs. Anyway, what I can say about the drugs that we're using now most of the time is they seem to indicate that the newer treatment outperform efavirenz. I'm not talking of dolutegravir as yet. So if we look at the recent trials, SCTG 5257, which was presented at CROI, what we can say is all is atazanavir, raltegravir, and darunavir are virologically equivalent in naive patients, but significant differences for tolerability. Well, talking about dolutegravir, which has been exciting a lot of people, of course, recently because of this, these studies which have now all come out with phase 3 studies showing some very interesting things. It's very potent, as you can see it here with the blue line. You can see that very quickly the proportion of patients become undetectable rises very abruptly and faster than with efavirenz, which is in gray. What we see is that also at week 96, the rutagravir and abacavir and 3-TC was superior to the combination where we use often, which is Truvade efavirenz. So now we've got a drug which has been discussed a lot during this meeting, and what is interesting is its resistant profile. As you see here, we've got no resistance in the naive studies. So basically, it's 50 milligram, it's once a day, and it is asking a lot of clinicians, the question how to use it. How to use it, particularly as there hasn't been treatment-emergent mutations in the naive studies. So it's basically in experienced patients that we have seen two types of resistance. And my long conversation with Mark Weinberg and long discussion I've heard of with Mark Nelson's sort of make clinicians and virologists into two camps. The first one is that there will never be any resistance appearing in naive patients, and the other one think, well, resistance always occurs after a while. Well, the good news that in experienced patients where it appears, actually this mutation is compensatory mutation. They decrease the fitness. So here we are. Now we have got these new drugs, and I think we will have to find the way to use it and how to use it in our patients. Now, as I said, the comorbidities are absolutely fundamental in our clinical care. It's been reviewed largely. Barry Peters did a very good review, and we have to assess all the comorbidities before we start treatment. But of course, we have to remember that the most important thing is to get the viral load down. So we've got an aging population. We have to consider the type of drugs, and not all protease inhibitors have been incriminated for cardiovascular risk in particular, and also bone frailty in association with tenofovir have got the same risk level. We do not have some data for darunavir, and we seem to have no increased risk with atazanavir. So the use of statins in our population of HIV-positive patients is very often discussed, and recently there was an article about increased risk of type 2 diabetes. However, the speaker concluded the benefit outweighs the risk. And the lipid levels is not the whole story. As we see between the increase in lipid levels in PIs and efavirenz with not the same cardiovascular risk. However, fundamentally, you have to stress the importance of lifestyle changes in your patients, weight, and mostly smoking. Smoking has been shown as a factor affecting mortality recently in the most dramatic way. So, here we are. If we talk about money and cost, we've got some generics already. We will have more generics soon. And here are the dates of the patent expiration, I think you say. Can't remember. Anyway, so let's go very quickly through the new ARVs. At CROI this year, there was a lot of presentation, and I think everybody is very excited. Why? Because they're very potent, less resistant, and again, as I've said, when are we going to use them? And a compound which should also seem to act on macrophage inflammation. So, the very, very exciting thing, I think, is the development of these long-acting compounds. And, of course, their role in prevention of the infection has been covered, and I'm not going to repeat that. They have advantages and probably unknown. I won't go into all the details, but, potentially the toxicity of injecting something which is there for a very long time, is probably not known yet. But we have potentially, also with the nano preparation, all sorts of advantages. So, I have taken them from Professor Gulick, and he has shown the various new compounds. I can't discuss them all, but as you can see, all classes are in development, and it's very exciting. Just a few compounds I'm going to just discuss rapidly, like he did, because I know them better than the rest of the compounds, actually. So, TAF, which is an NRTI, inhibitor, doravirine, which is an NRTI, cenicrivirox, sorry for the spelling mistake, which is a CCR5 CCR2 inhibitor, BMS 068, attachment inhibitor, and GSK 744, which is an integrase inhibitor. So we need more new NRTIs with less long-term toxicity, and also we've got multiple resistance in the clinic, so we need something which works against viral strain. Here comes stuff, okay? And to go quickly, it's potent, and also the phase 3 program has been completed, so news soon. So, doesn't move. Yes, there we are. So, NNRTIs, again, we need a few things, less toxic and better tolerability, and we need these compounds which are active against viral strains. And of course, the fewer drugs interaction. So, we've got doravirine, which is the Merck compound, and I think it's an exciting drug because it's active in vitro against quite a lot of resistant strains. Also, it is phase 2 dose finding has been done, and it's the 100 milligram which is going to be used. So, if I look at the great S44 inhibitor, integrase inhibitor, again, we've got some very exciting data with combination of 744 with rilpivirine, the LATE-1 study, and here are the results. And so this could be used as IM dosing. Now, the CD4 attachment inhibitor, it's a BMS-068, and it's a new mechanism of action. Just to say that it is potent, and it had a very good efficacy at 24 weeks, and the dose of 1,200 milligram once a day has been chosen. So CCR5 antagonist, we need a once-daily dosing, and we would like also to have a bit of anti-inflammatory effect with a CCR2 antagonist. So there we are, Senicriviroc, phase 3. And what is interesting is that they're trying to develop it as a once-a-day pill, and it could be an alternative to tenofovir FTC. Now, I'm coming to a presentation or presentations which have to deal with dual therapy or drug holidays. I cannot not talk of Professor Lebovich and his ICAR treatment, which is investigator-led, which produces always a little bit, I think, of controversy, but it's the use of antiretroviral therapy for 4 days, a week, triple or quadruple, and this was in a cohort of multi-treated patients of an average age of 52 years. So there seem not to have been any failures. However, we do not have a lot of data regarding this patient population. So, GADEL trial, and that's been published, and this made quite a lot of noise in the States. Basically, lopinavir, ritonavir with FTC, so dual therapy versus lopinavir, ritonavir, 3-TC and a bacavir triple. And basically, there is no problem in using the dual as far as this study is concerned. Now, if we look, and this is the study which was open label and phase 3 and non-inferiority trial. So, now NEAT 001, I'm sure a lot of you have participated in NEAT 001, and basically NEAT 001 with valtegravir, darunavir, ritonavir versus Truvada, darunavir, ritonavir, had problems at high viral load, so don't use darunavir at high viral loads. To finish on this part of the talk, just to say that I think for a long time we've been thinking that using protease inhibitors was a very good idea in resource-limited countries because of drug supplies, adherence, and other factors. And I think there's a very nice study from the Klumek group, sorry, which showed in particular that there was less PI-associated resistance than in the arm of the NNRTI arm. So this was an African study, and I think that this strategy should potentially be a better first-line option. So, eradication, is it okay, time-wise? Yes? Okay. So, eradication, very interesting. I mean, I think we've been thinking about it for quite a long time. And now it's very exciting because I think there is so much work done by virologists, immunologists, and pharmacologists and doctors. And I think it's a very exciting time. I think we've learned a lot about reservoirs in the last 3 years. And also, there's been a lot of attempts to use intensification of antiretroviral therapy, new pharmacological intervention, and also gene therapy. Must be forgetting something, but anyway. The bad news, I think, was summarized this afternoon, and really, as you know, we've got these stable reservoirs. Heart doesn't do very much. They're in a population which is long-lived, and they could produce replication-competent viruses when we stop treatment. The establishment of this latent reservoir is a very interesting matter. Thank you so much, because actually, as we've looked at for a few years, it is most probable that it is much lower when it is initiated during primary HIV infection. And the recent work by my friend and colleague, Jintana Nanvaranic from Thailand, and lately from Washington, D.C., has shown that actually if you treat very, very early, you can have hardly any reservoirs. But using the phoebic stages, you have to be phoebic stage 1 or 2. So it was shown this afternoon that the memory precursor CD4 T cells are cellular targets for HIV-latent infection clearance. And the problem is the CTL clearance doesn't occur, it seems, because of CTL gag escape variants, which dominate in chronic infection, but probably not in PHI. So I think the message is early art in PHI, because we've got a smaller size of latent reservoir, and the virus hasn't got all these escape mutants. Whether this can succeed in having post-treatment control is under investigation after the Visconti cohort study. I think that certainly we seem to be confirming that we're in much better position if we treat early than late. So, just to review very quickly the pharmacological approach, I do not know everything about these approaches, but all I can say is I think they look quite exciting because they try to target several arms of the immune response, and also they will hopefully be successful in combination. I had never heard about dehydrocortistatin A, I have to say, and I'm very interested by this. The HDAC inhibitors, the PKC activities, have been talked about much more. And one of the HDAC inhibitors considered the most effective is the panobinostat. And as you know, the vorinostat has been used quite a lot with no decrease of reservoirs. This later compound is 100 times more potent than vorinostat. So, we know that panobinostat induces HIV transcription. So we know also that this is very good news because we're trying to reverse latency. And in a cohort of 12 patients, this afternoon was presented that 9 patients stopped treatment out of 12, and the viral load rebounded. In the majority quite fast, but slowly in 3. And there was a trend in HIV DNA decrease, but it soon increased again. And there was a correlation with integrated DNA and the suggestion that changes in HIV DNA are useful to indicate how long patients can stay off heart. So, the gene therapy. My understanding this afternoon that it fails because you have only a low level of cells transduced, and I hope I'm right. So basically, there was a very interesting discussion about new compounds, and I think that the tree recombinase, which attacks the reservoir directly, for me was a very, interesting and intriguing new potential intervention. What I liked in it was that it seemed there was no oncology risk attached to this intervention. So the problem was that now it seems that it's been expanded to more subtypes because it was limited to subtypes A, and clinical studies are to come. So thank you very much for your attention, and I hope this was quite comprehensive.
So, good afternoon, ladies and gentlemen. So I have the great pleasure to make the HCV summary. Maybe the title can be the HCV eradication, but so I try in the next 15 minutes to make a summary of the morning presentation. So as you know, due to the high level of the knowledge of the life cycle of the virus, we know how, with the different target, how we can block the virus with the different new molecules. New molecules are mainly focused on entry inhibitors, mRNA inhibitors, and also host target inhibitors. But I think that this last classes of molecules that we can forget. And we have to be concentrate right now on the three main classes: is the protease inhibitors, NS5B inhibitors, and NS5A inhibitors. Regarding this last class, we don't know how this class of molecules act against the virus. So, and in the last 25 years, from the beginning of the starting with the interferon for the cure of the Hep C, of the hepatitis non-A, non-B, we move on the interferon-free combinations with, of course, some very active and efficient drugs. About the different drugs, we have three main classes with drugs. The main is the protease inhibitors, and with this different class with the first and second generation. The NS5A emitters of these drugs are very potent, and also the polymerase inhibitors with non-nuc and nucleoside. And certainly one of the most promising class and the backbone of the therapy of the Hep C right now is based on polymerase inhibitors, non-nuc. And of course, we have the Hep C revolution with one drug. This is the sofosbuvir. This is with all the name of the clinical trial is like the atomic bomb, because this is the proton-neutron atomic, and we observe with the combination of this drug with other drugs a high sustained virological response. So I will present. But in this tape that you are familiar, we compare both the efficacy response profile, pangenotypic activity, adverse event, and drug-drug interaction with both the protease inhibitors first generation to the NS5A inhibitors, NS5B inhibitors. And of course, with the first generation of drugs based on telaprevir, boceprevir, these drugs are classified as toxic drugs by the ASLD and also the EASL, so we have not to use currently this drug in our country, but certain countries, as we observed this morning, the drugs are just filed. And for the best drug, this is certainly in green, the NS5B inhibitors with a very potent efficacy, with a very good response profile, pangenotypic activity, no drug interaction, and no adverse events with this drug. So I think that if we have to classify this drug, we can classify from the potency with the genotype coverage, resistance, barrier, safety, and in a second priority with treatment duration, half-life dosing, potential drug interaction, metabolism, and also cost. But maybe the cost is becoming one of the key factors to select this drug. So on the different interferon-free strategy, we can right now combine this molecule to achieve SVR of, we hope, of 100%. And by combining the nuc base by the NS5A inhibitors with nucleosides, or nucleoside inhibitor with non-nucleoside with a third drug, or nucleoside inhibitor with the PI, and other combinations. So we have right now several backbone therapy, one based on nucleoside inhibitors, and another one not based on nucleoside inhibitors. And we have to combine three drugs or 3 or 4 drugs. This is a strategy developed by Abbott specifically. One of the key factors is how we can shorten the duration of therapy. And we have to use, we can come back on the viral kinetics model to define the notion of cure boundary. And from the 24 weeks, we have to decrease the duration of therapy to 12, 8, and maybe 6 weeks in certain populations. So we have to evaluate the shortened duration of therapy with this new very potent drug. So right now, what are the treatments that we have? We have the interferon-based treatments based on the first generation, boceprevir, telaprevir, but also with the sofosbuvir, cimeprevir, faldaprevir, with peginterferon in different genotypes, so we can achieve SVR of 90% or 80% with this combination, and also the different interferon-free regimen, combining sofosbuvir and ribavirin for genotype 2 and 3, or genotype 1 on genotype 4, and with 24 weeks, we can reach SVR of 75%, but we can combine also sofosbuvir with cimeprevir in genotype 1 or 4, with 12 weeks of treatment, and we can achieve more than 95% of SVR, or combine the 3D drug from Abbott in genotype 1 with 12 and 40 weeks of treatment, or sofosbuvir plus daclazavir, or the last one, the Merck combination, the second generation of protease inhibitor plus NS5A inhibitors. So with also a shortened therapy of 12 or 18 weeks of treatment. So what are the key factors it decided to treat or wait? There are patient factors. There is urgency to treat, likelihood of response based on HCV genotype, treatment experience, ILB 28 genotype or degree of fibrosis, and also a patient's motivations. So we have to make in balance with also the treatment factors, based of the efficacy of current options, the safety, the duration of therapy, the pill burden, the future option and the timeline, but also two main factors in several countries. This is the access of treatment and also the cost of the combination of therapy. Just to have just a look on the new classification of the EPSI, because we have to look on the 7 genotypes, not only 6 genotypes. This is the new classification of the EPSI. Of course, we don't know about a lot of virological assessment about the genotype, but we have also to have a look on genotype 1B and 1A on subtype, because of course we know that it's more difficult to treat the genotype 1A than the genotype 1B. So several combination therapy are addressed in patients infected by genotype 1B and other with genotype 1A. So we have French recommendations. This is the AFER recommendation. So in each recommendations, as I told, there are some recommendation for genotype 1A, 1B, in naive relapser patients or non-responder. In each combination that you can see, you have several options with peginterferon or without peginterferon by combining sofosbuvir. This is a backbone therapy based on nucleoside analogs, using sofosbuvir plus daclazavir or sofosbuvir plus cimeprevir in genotype 1A, 1B, genotype 2, genotype 3, and also for genotype 4. And genotype 4, 5, and 6, we can combine sofosbuvir plus peginterferon ribavirin. We have not still the data by the combination with interferon-free regimen. So this is the same also for the guideline, for the US guideline. We can also switch from the peginterferon ribavirin plus sofosbuvir with an interferon-free regimen in the different genotypes that this is in naive and relapser, and also in prior non-responder. We have also some recommendation and with some alternative. I would like also to stress your attention about that the triple therapy in HIV co-infected people. These are the results of the first generation with boceprevir and telaprevir combining with peginterferon and ribavirin. We have a high SVR of 63 and 74%, and with the cimeprevir, we have an increasing SVR, approximately between 80%. With the faldaprevir, also second generation of protease inhibitors, 70%. And with the sofosbuvir, we have 76% of SVR. This is very, very interesting. And more interesting maybe, this is by combining DAA altogether without interference. This is a study done by Merck, and with a protease inhibitor second generation and S5A inhibitors with second generation, plus ribavirin. And as you can observe, this is approximately between 90 and 100% of SVR in HIV co-infected patients. So these drugs are very effective. And news is that we can retreat genotype 1 patients with failure to the third generations. And the good news is that if we treat these patients with the sofosbuvir, we can achieve, or maybe with other drug or other DAA, we can achieve also 100% of response. So this is very good news. Also in post-transplant hepatitis C, we can have a very high level of SVR that we can observe in this combination therapy of interferon-free regimen with the 3 drugs of Abbott plus ribavirin. You can achieve more than 95% of SVR in this patient. So if we have to make a summary of the DAA therapy in HCV co-infections, the recent past is based on the boceprevir and tenofovir. The present is based on the sofosbuvir combining with simultaneous and daclazavir. And the coming future is this is certainly the single tablet regimens, maybe on the next year, by the combination of in the same pill 2 or 3 drugs that will be a pair. So on the all interferon-free, with the simultaneous, we have 1 pill per day, and the times of treatment is 12 weeks for genotype 1 and 4. There is drug interaction, so we have to manage. With the daclazavir, is also treatment based of 1 pill per day, 12 weeks of treatment addressed in 1B, not in all the genotype. For the Abbott is 1 or 2. We don't know exactly pill per day, BID, 12 weeks of treatment addressed in genotype 1, with also some drug interaction for sure, because there is 3 or 4 drugs. With the sofosbuvir and ladislavir, one of the most promising combination therapy in STR. This is also with 8-12 weeks of treatment for cover all the genotypes without any drug interaction. And with the Merck combinations, also it's 1 pill per day. It's with 12 weeks of treatment addressed in genotype 1, and we have to manage also the drug interaction. So, in conclusion, with this true therapeutic revolution, we have the SVR rates of 90% with the DAA therapy, but we have also to manage some difficulty to treat populations, the failure of PI-based triple therapy. We have to managing the difference between genotype 1A and 1B, different IL-28B genotypes versus naive versus non-responder, the genotype 3 cirrhotics with treatment failure, the pre- and post-transplant patients, the drug addicts and substitution, and also the HIV co-infection, and manage the drug-drug interaction. There are some remaining questions. The treatment duration is 12 weeks enough, and maybe we can shorten the therapy at 8 weeks to save money. What is the resting place of the ribavirin? We have there is dispensability. It depends on the regimen. And of course, the resistance is still an issue. So the global question is for the patient screening in different geographic issues according to previous screening strategies, the treatment access with identification of patients around the population, organization of the health system, the organization of medical care to manage a high burden of patients, and of course the cost of therapy, because the cost of therapy is enormous at this time, and efforts to be made by pharma industry. So in conclusion, because HCV is eradicable, the first will be the winner, of course. And right now, there is in this course there is of course some winners at this time, but maybe with the time the last one can be become the first one. We don't know. And to finalize, maybe in less than 10 years, maybe there will be the HCV eradicated or eliminated for the planet. Thank you very much for your attention.
So, just one more thing before saying goodbye and thank you. The abstracts are now live on BMC infectious diseases, so you have to go to the website and to click on supplement to find all the abstracts of this symposium. And the last message already given by Jean-Pierre Routy is that we will be happy to meet you again in 2 years with another kind of meeting where HIV will still be at the center of the subjects, but other viruses too. So thank you. Good night, and see you in 2 years.